Hi everyone, welcome to the presentation Contemporary Issues in Nutrition and Lifestyle, an evidence-based question and answer. My name is Scott Stolte. I'm the Dean of the College of Pharmacy at Roseman University of Health Sciences in Henderson, Nevada. It's my pleasure to welcome you today and to deliver this particular presentation because for those of you that have attended my presentations in the past, you know that they are primarily drug-focused, primarily medication treatment-focused, and while this particular presentation will have some aspects of medication-related therapy in it, I know as a pharmacist, and I'm sure you as a pharmacist, outside of medications, probably the second most frequent category of questions you receive from the patients you serve are questions related to just living, whether it be nutrition, lifestyle, exercise, those types of areas where you are, as a pharmacist, as a pharmacy technician, even very accessible to patients, and patients don't necessarily want to schedule an appointment with their physician or with another healthcare provider to talk about these lifestyle issues. So, as the accessible pharmacist, you often become the person that is asked related to these matters. And so I think that as a pharmacist, we need to be at least somewhat prepared to address questions related to nutrition and lifestyle. We should also think about for our patients if they do have in-depth questions, if they want to get started on a fairly significant lifestyle transformation. We should also have referrals in hand, people that we can, healthcare professionals, athletic trainers, physical therapists, dietitians, nutritionists, that we can refer patients to for those patients that really want to do significant transformations, because we as pharmacists can certainly help patients and should help patients. But again, this is not necessarily our area of expertise, so we need to work with the professionals where this is their area of expertise. So the way that we're going to do this presentation today is it's going to be a Q&A type format. And just one caution before we head into this presentation. As with most of my presentations, it's going to take fairly recent studies and provide some practical application of those studies. Now, with nutrition and lifestyle, one thing I think it's important to be cognizant of and cautious of is these are just snapshot type of studies. These need to be considered in a broad spectrum of a person's lifestyle, of all the habits that a person does. So I don't want you to think, for example, after this presentation, that it's okay for a person to go out and eat all the eggs that they want every day. That's not really what the study is showing. And that's a little bit of a teaser. We'll get to that study in just a little while. Just use caution, use your good judgment. These are studies that are helpful when we look at patient behaviors, but we do have to look at the patient as a whole person and not just as a component of that person. And I think you'll see what I mean as we go through this presentation. So just be cautious, use your judgment, use your common sense as a healthcare professional, and with that, also use these studies that I think are very interesting, that show some things that in some cases are a bit counterintuitive to what current thinking is, and I think you'll enjoy it. So the objectives of the presentation are to describe two contemporary issues related to nutrition or lifestyle and their impact on the individual and or population health. Second objective is to summarize the findings of recent clinical trials related to the effects of nutrition and lifestyle on health. And third is to compare and contrast the findings of recent clinical trials with commonly held beliefs related to nutrition and lifestyle factors. And that third objective, I think, is where I want you to, as we go through these, think about what is the current belief, and are these studies actually showing a result that's different than what people currently believe? And I think in some cases they are. So I thought I'd get your attention with the first question, and it's fact or fiction. Drinking coffee has health benefits. So I'll give you just a second to think about what you think that answer is, and then we'll get right to it. Okay, as a background, there's been many past epidemiologic studies conducted related to this topic of coffee and health benefits. Most of them have been very small, very underpowered, meaning they did not actually have the number of patients necessary to prove any kind of statistically significant result, and there's been some conflicting results. However, now we do have, in the mid-90s, the National Cancer Institute conducted a detailed diet and lifestyle questionnaire to members of the AARP, and about 402,260 members of the AARP. That is a study that is not small, not underpowered, certainly does have the numbers to show the results that we might be looking for. And the study is Freedman and Associates. The participants of the study, they were age range of 50 to 71 years old. They had no heart disease, and this is important. They had no heart disease, stroke, or cancer at onset. And when you think about why might this be important, well, we don't know if the patients had high blood pressure or not, but certainly high coffee consumption would lead to somewhat high caffeine consumption if it's caffeinated coffee. And that might have adverse effects on blood pressure, thus may actually lead to complications related to heart disease. So the fact that the patients didn't have existing heart disease is fairly important. They followed these patients for 10 years. So with that patient number and with that follow-up for 10 years, you have approximately 5.1 million person years of follow-up. I don't think you're going to find too many studies that have more patient years than that. And certainly this is the largest ever study to examine the relationship between coffee consumption and health factors. The results of this study, and believe me, when I shared this with my wife, she was quite happy. I'm a person who I don't drink coffee or caffeine of any type. I just don't like the way that it makes me feel. But my wife is a regular coffee drinker, and I don't think she could go without coffee. So the results overall, the risk of death was increased among coffee drinkers. However, what was found in the study that coffee drinkers were also more likely to smoke than non-coffee drinkers. So when that was found, then the results were adjusted for tobacco smoking status and some other confounding variables that were associated with coffee intake. And what was found after those confounding factors were controlled for, particularly tobacco smoke. So what you do is you find the association between increased coffee consumption also related to increased tobacco consumption. You remove people who smoke, and you look at the results again. And when those people were removed, when the smokers were removed, there was a significant inverse relationship between coffee consumption and mortality. Now, I want you to think about what that means. There was an inverse relationship between coffee consumption and mortality. What's really important about that was the relationship was graded and inverse. So what that shows is the more coffee that was consumed, the lower the mortality. And you think to yourself, well, there has to be a cap to that. It couldn't go on forever. Well, I think when we get to the actual subgroup analysis here, you're going to find this very interesting. So the results: decreased total mortality and disease-specific mortality among coffee consumption for heart disease, for stroke, for respiratory disease, for diabetes, for infection. And the results were not significant with deaths due to cancer, meaning it didn't increase deaths due to cancer, but also didn't lower it. What I've found really interesting about this is the results were similar among subgroups, including men versus women, baseline health, and caffeinated versus decaffeinated coffee. Now, as you know, even decaffeinated coffee has a little bit of caffeine in it, but decaffeinated coffee seemed to have the same benefit. In terms of the discussion, because I think this is where it gets really interesting, the study was observational in nature, so it was essentially just looking at behavior and what a behavior did. It was not designed initially to determine a causal relationship. So this study was not initially set up for the sole purpose of looking at, does coffee cause these health benefits? The study was set up for another purpose, but this just happened to be data collected as a part of this study that was used for this analysis. Trends were found to be very significant. And what I find really interesting is men who drank 6 or more cups of coffee per day had a 10% lower mortality than those who drank no coffee. Women who drank 6 or more cups per day had 15% lower mortality. So we're not talking about people just drinking a cup or two a day. We're not really, in this case, talking about a necessity or importance of moderation. It seems that the relationship is, just like it said, graded and inverse, meaning almost the more you drink, the better. And why is the question? Well, certainly at this point, the study was not designed to determine why. The components of the coffee were not analyzed to look at what was actually protective versus what's not. But the authors speculate that it's antioxidants. I think if we have a finding like this, that's going to lead to we got to figure out what's going on here. But again, very, very interesting study, and the take-home point is that certainly even caffeinated coffee does appear to have some health benefits. The nature of those health benefits is not really defined at this point. And as with all the presentations that I do, I include the reference, so if you're very interested, you can read it for yourself. The interesting thing about this study, I think, is that the tobacco smokers were removed, and you can look at the methods and see if you agree or don't agree with why the study why the study participants decided to do that. So, fact or fiction, being overweight or obese leads to increased mortality. This is a little bit of a trick question because it's not really fact or fiction. Some of it is fact and some of it is fiction, and you'll see what I mean when we go on to the study. So as a background, the relationship between overweight and obesity to mortality has actually been inconsistent. Some of you may even find that surprising, that studies have not routinely demonstrated that being overweight actually is as detrimental as you might think. Studies have been done, many studies. However, the problem is that the definitions of overweight and obese have been inconsistent in those studies. So what Flegal and Associates did is they conducted a meta-analysis of 97 studies. Meta-analyses are compilations, usually of controlled research. And what they bring is they bring higher power to detect significant differences, and that's why you do meta-analyses. So this study had 2.88 million study participants as a part of the 97 studies, more than 270,000 deaths. The important part about this study is that the weight categories were standardized, and that's what a lot of these studies in the past have not done. So you've been trying to extrapolate results between different categories of weight. So this study normalizes or standardizes those weights. So normal weight is a BMI of 18.5 to less than 25 kilogram per meter squared. Overweight is BMI of 25 to less than 30 kilogram per meter squared. Grade 1 obesity is a BMI of 30 to less than 35 kilogram per meter squared. Grade 2 obesity is a BMI of 35 to less than 40 kilogram per meter squared. And grade 3 obesity is BMI of greater than or equal to 40 kilogram per meter squared. And the results of this study, and like I said, some of you may find this surprising, compared with normal weight participants, all-cause mortality was significantly, and that's statistically significantly lower. Now, if you look at a hazard ratio of 0.94, you may say, it's not probably not clinically significantly different, and I would say, there is a difference. It's not all that large, but anyway, all-cause mortality was statistically significantly lower for overweight participants, and it was actually similar for grade 1 obesity. So really, there's not a lot of difference in all-cause mortality between normal weight, overweight, and or grade 1 obesity, which I think most of you will find to be somewhat counterintuitive, especially given what we hear so often now on media, news. However, the all-cause mortality was higher for grade 2 and 3 obesity, as expected. So, as far as a discussion, this is not the first time this has been demonstrated. But it is a higher quality investigation, and actually to be more specific with some of the other studies that have been done, it appears that especially as a person ages, gets to be that truly elderly person, 75, 80, 85, classified as elderly, certainly not everybody that's that age acts elderly or behaves as an elderly individual, but becomes older, actually a little bit of weight above normal weight appears to be somewhat beneficial. Now, in younger life, especially midlife, the relationship is a little bit more hazy. There's almost a time in life where cardiovascular risk is at its peak, where it does appear that being normal weight is beneficial, but especially as a person ages, being somewhat overweight appears to possibly be somewhat protective. So this isn't the first time it has been shown. It calls into question the assumption that overweight and low-grade obesity are associated with early all-cause mortality. Now, when you think about what that means, that's a pretty standard assumption at this point. I think we would all say that the general assumption is the lower the weight, the thinner the person, the better. This study certainly calls that into question. However, one thing that this study did not look at is you do have many overweight people, probably even some level 1 obesity people, who are very high fitness categories. They may be very fit, but not necessarily meet the criteria according to BMI for being normal weight, and this study did not address that. This study also calls into question the efficacy of BMI as a measure, and I think that we don't need to discuss that. That has been questioned for long enough now that really all of us know that it may not be the best measure anymore. BMI doesn't account for demographic, racial, or other differences in how fat is stored. At this point, it's pretty clear that central adiposity or extra weight, especially around the midsection, closely proximal to the organs, is more detrimental than adiposity in other areas, the hips, for example. And also, the study did not address morbidity among obese patients. And this calls into question, and the editorial for this article actually brings up a very important question. Have we traded mortality or death for morbidity and lower quality of life? Meaning, are overweight people, significantly overweight people, developing more disease and having a lower quality of life, but nonetheless still living longer? Anyway, I think it's interesting because it does call into question that relationship between mortality and higher weight. And I have your reference for you there. Okay, here's another interesting question, and I think there's no doubt that the influence, the presence, the purchasing of organic foods has grown significantly, especially over the past 5 years. It really, the organic food growers really started to grow in popularity about 15 years ago. You started to see organic foods as somewhat mainstream in grocery stores about 10 years ago. And for about the past 5 years, even people who have otherwise not been really interested in organic food movement have been making choices for organic food. So I think that shows that to some degree the assumption is that organic foods are better choices for people who have higher healthcare concern, have higher healthcare awareness. So are organic foods safer than conventional foods? As a background, U.S. sales of organic foods rose from $3.7 billion in 1997 to $27 billion in 2010. So that's a period of 13 years, and you had about a 900% growth in the sales of those foods in that time. Health is the most common factor often cited for purchase of organic foods. Better nutritional value, including people believing that organic foods have higher vitamin and nutrient contents, is another area that's cited when people choose organic foods. So essentially it boils down to when people choose to buy organic versus conventional or non-organic, really boils down to two things. Number one, they feel that those foods are safer, they don't have pesticides, what have you. Number two is they feel that they might actually have better nutritional value. So a study was done to see, are those thoughts, are those assumptions to any degree true? And the study was Smith-Spangler and Associates. It was a systematic review of 240 studies, and it compared organic versus conventional or non-organic foods for health benefits and health risks. One thing that the study did not do was to standardize organic and conventional methods. And I think that's an important consideration as we talk about this study because are we really looking at the difference between organic versus conventional foods here, or are we looking at in this study a comparison of different organic and conventional practices, meaning are some organic standards for farms, foods, what have you, better than others that are still classified as organic, and are some conventional or non-organic food standards much higher than others that are classified as conventional or non-organic. Certainly the best study in this area would have been to standardize those farming, those food gathering practices. This study did not do that. Still, I think it's somewhat interesting to look at the results. So, in terms of the results, comparing organic versus, and by the way, these organic foods did have to meet the USDA criteria for organic foods. So this is not a situation where it's a food grower, food manufacturer just saying it's organic. They did have to meet USDA standards. So comparing organic versus conventional foods, there were no significant differences between organic and conventional in terms of vitamin content. So that means that that second point of, do they appear to have higher nutritional value? Well, at least in terms of vitamins, the answer in this study was no. There was no significant difference in prevalence of bacterial contamination in produce, chicken, and pork. There was no significant difference in heavy metal contamination for produce. However, there was a 33% less risk for isolating bacteria resistant to greater than or equal to 3 antibiotics in chicken and pork. And I think this is an important finding, especially for people who do make that choice to buy organic products. Another one of the determinants that comes up under safety concerns, I think, is that those meats, the animals have been exposed to multiple antibiotics as a part of their their process of being raised. And at least in this particular study, it does appear that in chicken and pork, they do have bacteria isolates that are resistant to greater than or equal to 3 antibiotics more frequently in the non-organic foods, and 21% less likely to detect pesticide residues in the organic versus conventional foods. So if you think about those two safety concerns, which are fairly big in terms of why people choose organic, less multi-resistant bugs, less pesticides as a part of the foods, then that appears to validate to some degree why people choose organic versus conventional foods. In terms of discussion, I think that let the debate continue. To me, in reading this study, I think, to some degree it invalidates some of the reasons that people choose organic, but it validates some others. So I think that, you need to make your choices based on that information. You need to be honest with your patients or people who ask about this to a pharmacist. Again, this is, pharmacists mostly deal with drug questions, but these other types of questions are the types that pharmacists do get at times. So I think, having this information helps you to prepare. This study did not look in any way at long-term health effects, and I think that's, of course, important to know. All you're looking at are those factors that were presented in the results of the study. Didn't look at any health, any disease processes at all. Studies were likely confounded by many factors. Like I said, no standardization of farming systems, whether they were non-organic or organic, and that certainly does complicate the findings of the study somewhat. Nonetheless, I think it's an interesting study, and of course I provided you with the reference. One thing to note in this study, this is not out of some non-traditional food journal. This was actually presented in September of 2012 in the Annals of Internal Medicine, a very, very highly respected journal. So I think that, in terms of study methods, I looked at those very closely. It actually is a very high-quality medical study, so something I would be confident presenting and talking about with patients. Okay, another interesting fact or fiction, and this one actually does deal with a medication product, one that we see every single day as pharmacists. And I think this deals a little bit with some misconceptions that your patients may have about medications. And, well, at least I can say that the patients that I work with certainly do have this misconception. And if you don't believe me, just ask them. And that misconception is that if I have high cholesterol and I take statins to lower it, do I really have to do anything else in terms of lifestyle modification, healthy diet, exercise, what have you? Of course, some of your patients, for them, the answer is going to be yes, I need to do both those things. But for many, many of your patients, they really do believe that the medication itself is the cure. The medication provides all the help they need to control that cholesterol, to get them to the point where they are healthy. And so this study doesn't really address that question, but I think it will help you talk to your patients about, does exercise really make a difference, and has exercise actually been shown to make a difference? So fact or fiction, statins are more effective than exercise in decreasing mortality in patients at risk for cardiovascular disease. So am I less or more likely to die of cardiovascular disease if I take statins than if I just exercise? I think that's an important question. So as a background, from other studies, and certainly this is an area that's been well studied over time, we know that both statin use and increased activity lower mortality in patients at risk for cardiovascular disease. That's not really something that we need to look at anymore. However, these two methods to lower that mortality have not been directly compared, which is very interesting. So few data compare, and the existence of synergism, surprisingly, is not all that established. Meaning that I think we always tell our patients, well, take the drug and exercise, and you'll get better results. And we think that because that seems to be somewhat intuitive. However, in terms of how the data goes, that really hasn't to a very strong degree been proven. We like to prove things in medicine. It's a good idea that we have proof behind what we're telling our patients, so that certainly it's validated. Kokkinos and colleagues did a study. They followed 10,000 military veterans. All of the patients had dyslipidemia, and they were followed between 1986 and 2011. And believe it or not, yes, the statins have been on the market since 1986. I know it's for some of you, it probably doesn't seem like it could possibly be that long. Because it was a veterans study, we had about 97% men. So anytime you have a study like that, of course, these results are not going to be necessarily be able to apply to women. And 52% were black. All the patients underwent exercise tolerance tests. Patients were assigned to one of 4 fitness strata based on those exercise tolerance tests. So they used the exercise tolerance test to determine the level of fitness of the patients. Patients were also assigned as either statin users, which meant at least 3 months of statin use, or non-users, and they were followed for a period of time of about 10 years or so. As for the results, statin use and better fitness were associated independently with lower mortality. So that's just essentially reestablishing what we already knew, that both of them lead to lower mortality. However, what this study does that's interesting and really hasn't been established to a large degree up to this point, among the statin non-users, the most fit had significantly lower mortality than the least fit. So level of fitness does matter in terms of mortality. Among statin users, the most fit had significantly lower mortality than the least fit. Now this does answer one of the questions that really had not been answered, is that synergism effect. So even among statin users, fitness still makes a difference. So this is great. We can look to our patients and honestly tell them what we've told them all along, that if you use a statin and you have a high level of fitness, your mortality is going to be lower than a person who just takes the statin and does not have a high level of fitness. Again, we've probably been saying that for years, but here's the proof. That's the great thing. What's, again, another interesting finding of the study is moderately fit statin non-users. So people who did not take statins at all but were moderately fit had a mortality risk equal to the least fit statin users. So what that means is if a person is moderately fit, not taking statins at all, they have the same mortality as a person with low fitness who takes a statin. So what that means is that both exercise, both fitness and statin use are good, but synergism is better, which is important, and there is a fitness level where you can actually get the same effect of the drug. And keep in mind that this is a moderately fit. That doesn't take into account the two higher stratas of fitness that actually would be more beneficial in terms of mortality than statin use. So the important take-home of this is that fitness does matter, and that statins together with fitness level have synergism. And again, many patients do feel that lifestyle modification is not needed if they're treated with medications. And you may be thinking to yourself, really, I don't think patients believe that. Trust me when I tell you that they do. Patients do believe that. If you don't believe me, just ask them. Not everyone will say yes, but some will say yes, that's true. I believe that the statin takes care of the problem. Better results were achieved with statin use and high fitness. Physical activity in general is safe and effective for almost everyone. Now, I do want to say here, this is an important point, especially for pharmacists. If you have an exercise-naive patient, a patient who has never exercised before, and they're older than about 30 to 35 years old, be careful in recommending that those patients jump in to a full exercise regimen. They should have some type of evaluation by a physician prior to doing that, just to make sure that they don't have any underlying heart condition or so forth. I always do that just to be safe, to make sure they at least have, rhythm checked. Physicians in that case, if they have never exercised before, may actually choose to do a base EKG, which is fine. Again, it's looking for those underlying arrhythmias. Physical activity is safe and effective, though, for almost everyone. And physical activity is a very inexpensive alternative. What you have to do is you have to get people to commit to it. You have to get people to continue to adhere to those fitness regimens, and that can be hard. If it was easy, everybody would do it, right? And again, there's the reference, and you can see this is published in Lancet, another highly reputable journal. So, fact or fiction? Increased egg consumption leads to increased cardiovascular disease. And depending on what age you are, I'm sure some of you remember the period of time when eggs were kind of the best case scenario in terms of food choices. And then you remember that all of a sudden eggs became bad and no one should eat eggs, especially egg yolks. And so where are we now? What do we know in terms of egg consumption now? I think many of us at this point probably still have patients that are receiving the advice of, if you have high cholesterol, don't eat eggs. Well, is that or is that not true? Is that good advice, bad advice? What should we be telling our patients? So as background, as I said, the American Heart Association recommends consuming less than 300 milligrams of cholesterol daily. One chicken egg contains about 200 milligrams of cholesterol each. Now, I don't know about you, but I don't hear too much about the one egg omelet. It's a pretty small omelet. Wouldn't be happy with that if I went out and got an omelet. So you got to think that most people, when they eat eggs, are probably eating 2 eggs, maybe even 3. In some cases, if you're really going wild, maybe 4. But so if you eat 2 eggs, let's just say, that's 400 milligrams of cholesterol. You've already put yourself over the AHA recommendation. So clinicians, as I said, commonly advise patients with high cholesterol to avoid eating chicken eggs. However, the association between those eggs and really cardiovascular disease is pretty unclear at this point. So what is that advice based on? It's really based on the amount of cholesterol. So someone, and I'm glad they did this because I actually really like eggs, decided to do a study. Rong and colleagues did a meta-analysis of 17 prospective cohort studies which measured egg consumption. So again, these studies were not designed to look at, are eggs bad or good? They were studies for other purposes that did measure egg consumption and included some of the measures that we're going to look at, including heart disease, stroke, so forth. So the analysis included 9 reports on coronary heart disease, 8 reports on stroke, and 10 to 20 years of follow-up in most of the studies. And the results are these. There was no association at all between egg consumption and coronary heart disease and stroke. Of the subgroup of patients with diabetes, when highest and lowest egg consumption was compared, there was higher risk of coronary heart disease with a relative risk ratio of about 1.5 in patients with the highest egg consumption. So in patients with diabetes, it gets a little bit more complicated. It does appear that there might be some relation there. However, there was a lower risk of hemorrhagic stroke, which is interesting, and I don't think there's any really good explanation for that. So, in terms of conclusions, discussion, the study suggests that most patients don't need to avoid eggs, or really necessarily even limit eggs all that much. The exception may be patients with diabetes, where you might advise those patients to comply with the AHA recommendations much more strictly, the less than 300 milligrams. This is consistent with the results of other metabolic research. Dietary saturated fat and trans fatty acids seem to affect cholesterol more than dietary cholesterol. The focus for American Heart Association, other organizations, has always been or in the recently past has been the amount of dietary cholesterol that is taken in. The more evidence that we get, the more it appears that dietary cholesterol is probably not as important as saturated fat and trans fatty acid intake, and that's really what we need to be measuring more in foods. And to many people's credit, those are being reported more commonly on food labels. The good thing about eggs is they're very inexpensive. They're rich in protein. They have quite a few other nutrients. And if a person truly wants to avoid the cholesterol, it's easily avoided by removing the yolks. Egg whites, also excellent source of protein. The research continues to show in any number of areas that people having high protein breakfasts in particular tend to be have more moderate waist, tend to have less risk for obesity. Performance measures in terms of activity level throughout the day are higher. So for all of you out there who are not breakfast eaters, one thing that you might consider is a high protein, fairly low calorie breakfast that could be provided by any number of food sources, including egg whites. And again, there's the reference, and that was from the British Medical Journal. Very highly reputable, very well respected. Okay, here's one. Certainly at this point, you probably have many patients, maybe yourself, who take a very high, very large number of vitamins and antioxidants. And the question is, why do people take them, and do those vitamins and antioxidants actually do anything for people? Well, one of the most common reasons people cite for taking vitamins and antioxidants is that they prevent cardiovascular events. So do they? Fact or fiction, do they actually prevent cardiovascular events? As a background, some observational studies, not very controlled studies, have linked fruits and vegetables to lower cardiovascular risk. Many trials have been done with supplements and have really yielded highly conflicting results at this point. Most meta-analyses involve individual supplements, and this is the very first meta-analysis to include the comprehensive randomized trial data. So this is Myung and colleagues. It was a meta-analysis of data from 50 randomized controlled trials, 295,000 participants, and this trial assessed the efficacy of vitamins and antioxidant supplements in preventing major cardiovascular events, including cardiovascular-related death, heart attack, chest pain, stroke, sudden cardiac death, and TIA. And the results were supplementation had no effect on any of those major cardiovascular events. So no effect on cardiovascular risk by primary versus secondary prevention, meaning whether a person had already had existing heart disease or did not have existing heart disease, it didn't matter. The type of vitamin or antioxidant didn't matter. The duration of treatment didn't matter. Single versus combination supplementation didn't matter. Study design didn't matter. Study quality didn't matter. Whether a study was industry funded didn't matter. No matter what was the input, the results over and over again showed that supplementation had no effect on the risk of any major cardiovascular event. Well, certainly as we go to the discussion, that's interesting. I think most people would have assumed that there would have been some type of benefit, especially if we're looking at combinations of supplements. So where do we go from here? I am a person who takes a multivitamin every day. The reason that I take that is that I think and hope that it has some type of health benefit. So does that call that into question? Well, It might. Again, this did only look at cardiovascular events, so potentially looking at other possible disease states, other possible disease courses, the supplements may have some benefit there. So vitamin antioxidant supplementation did not prevent major adverse cardiovascular events. Interesting quote from the study authors in this trial that I just decided to pull for you, because I think it's rare that we have study authors just come out and say something definitively, and here we do. There is no evidence to support the use of vitamin or antioxidant supplements in the prevention of cardiovascular disease. As I said, other diseases or uses that are not addressed include cancer prevention, diabetes prevention, or quality of life. Very interesting study, published in British Medical Journal in January 2013, very recent. Some of you may have heard the results of this. This did make first run in several news sources, but I thought you should be aware. Moving along the supplement line, I think another frequently cited supplement for benefit is omega-3 fatty acids. So fact or fiction? Omega-3 fatty acid supplementation provides the same stroke benefits as fish consumption. As background, both fish consumption and omega-3 fatty acid intake have been in the past associated with lower coronary heart disease risk. Benefit for stroke has not been established, and that includes ischemic stroke, hemorrhagic stroke, or TIA, transient ischemic attacks. So Chowdhury and colleagues did a study where they looked at fish consumption. It was a meta-analysis of 21 prospective cohort studies, 675,000 participants. They also looked at omega-3 fatty acid dietary intake, 14 prospective cohort studies, 305,000 participants, and they looked at omega-3 supplementation. So you essentially have fish consumption, omega-3 fatty acids consumed in the diet, omega-3 fatty acids as supplemented, and then these were compared. The results are fish consumption compared with weekly consumption of less than 1 serving of fish. 2 to 4 weekly servings of fish were associated with 6% lower stroke risk. Greater than 5 weekly servings were associated with 12% lower stroke risk. In those that got the omega-3 in their diet from other sources, no risk decrease. And in those that had omega-3 supplements, no risk decrease. Remember, though, this is important. This is just for stroke. We already know that omega-3 fatty acid intake, really regardless of source, whether it be diet or fish or supplementation, does appear to have coronary heart disease benefit. So in stroke benefit, fish consumption reduced risk, supplementation did not. The question is, what in the fish leads to this reduction? It is probably more than one component. Many of the trials in fish consumption were observational. There were many confounding factors, including the one that the very first thing I thought of when I read these studies, and that is people who consume a lot of fish might participate in other very healthy behaviors. And that is true, and that was not adjusted for in this study. So that is a fairly large variable that was not controlled. Again, published in the British Medical Journal last October 2012. Another supplement issue that I think many of us deal with, many of us talk to people, is calcium supplements lead to more cardiovascular risk than increasing dietary calcium intake. Calcium is very interesting for a number of reasons. First of all, we know that, especially for people with osteoporosis, osteopenia, women of all ages, calcium is very, very, very frequently recommended. Whether you know it or not, the evidence to show benefit to that recommendation is not very good. In fact, it appears that the most important time for women especially to take in more calcium is exactly the time when women are at their lowest point in calcium intake, and that is adolescence, teenage years, up to lower 20s. That really appears to be the time when calcium supplementation, the increased calcium intake, can have the absolute most benefit. By the time that we are actually telling women, focusing on women to take their calcium, it doesn't appear that there is as much benefit to that. However, that's secondary to the study that I'm talking about. So fact or fiction, calcium supplements lead to more cardiovascular risk than increasing dietary calcium intake. As background, as you know, calcium supplements are widely used to minimize the risk of osteopenia and osteoporosis, especially in older women. And as I said earlier, as an aside, most important time for calcium intake is much earlier in life. So do supplements, what this really boils down to is, do calcium supplements promote vascular calcification and thus increase cardiovascular risk? Lee and colleagues developed a study of 24,000 participants. It was actually a German study of cancer and nutrition. The average follow-up was 11 years. They analyzed the effects of calcium intake, dietary and supplemental on cardiovascular events and mortality. And the results in that study that had 24,000 participants, there were 354 heart attacks, 260 strokes, and 267 cardiovascular deaths occurred. There was no increased risk for any of those categories, heart attacks, strokes, death, for women with increased dietary calcium, for people with increased dietary calcium intake. However, the use of supplements of calcium was associated with an increased risk for heart attack. Now, look at this number. This is a hazard ratio of 1.86. That is almost 2 times the risk. A hazard ratio of 2 would be 2 times the risk of not. So use of supplements had almost 2 times the risk for the events of heart attack, stroke, cardiovascular death. No increased risk for stroke, no increased risk for cardiovascular death. But the increased risk in heart attack should get your attention. The number of events in supplement users, however, was small, so that is a limiting factor in this study. The point of this is this is just one of several analyses at this point to suggest that calcium supplementation is associated with cardiovascular risk, while dietary calcium intake is not. This is, like I said, this is not the only study in this area. I think that when you recommend calcium supplementation to people, if you do that routinely, you need to be aware of this data. So I think you should read this study. This study will bring you to other studies that have been done in that area. It's important that you're informed. Why is this true? Well, the theory is that supplements may raise serum calcium concentration higher, may lead to vascular calcium deposition, and it may be best to reserve supplementation for when the benefits clearly outweigh the risks. And again, I gave you a couple citations here. I think it's important that you take the time to look at these if you are recommending calcium supplementation to people, to patients. I really hope that you've enjoyed this presentation. It's a little bit different than what I have done in the past. However, I think that it brought up a number of interesting topics, probably topics that you're dealing with in your patients every day. I know that most of you, a large percentage of you, probably get a lot of questions about especially vitamins and supplements, and I feel that as pharmacists, those do really fall in that category of medication-related questions, and we need to be somewhat prepared, as prepared as we can be, to answer those questions. One thing that we face as pharmacists that I think people underestimate the difficulty of is if a patient is very focused on one area, say for example non-traditional therapy, it's difficult for us as pharmacists to be as knowledgeable as patients in that area because they have access to all the resources that they could possibly want now via the internet. But if a patient brings you questions, one thing that you should be able to do as a pharmacist, as a healthcare professional, is to know where to go to do the research that's necessary to bring up your expertise, to be able to talk with your patients about the things that they want to talk to you about in a highly educated fashion. And so one of the goals of this presentation is just to increase awareness that, I know in the past it has been my excuse, maybe some of your excuses, that, well, those topics are not really looked at systematically. There's not a lot of data to show this or that. In some cases, there actually is data. You just need to take the time to look for them and to be educated. And so again, I hope this has been interesting to you. We have almost exactly 10 minutes for question and answer. Certainly I'll answer questions about these topics. If you have other nutrition and lifestyle questions that you'd like to ask, I will certainly take those questions, just with the caveat of, again, if you have an area of interest that's highly specific to you and you've done a lot of reading about it, there's a chance that I may not know much about it. So my answer to you may be, I don't know, and I would ask that you be patient and accepting of that, just like you would if a patient asked you a question that you did not know.